All right. So before we jump in, and I know since I can't see all of your bright professional faces on Zoom here, if you could just put in the chat where you are from originally, that'll be kind of my icebreaker. We'll just get to see the variety. I always like to see from hometowns where people are all from here. Um, and I'd be happy to share mine as well too here. So. Oh, we got a good variety here. Look at that. Okay. Jackson, Missouri, Dubuque, Iowa, Colorado, California, Kansas City, two Iowas, New England, South Dakota, St. Joe's, Missouri, Hastings, Nebraska. Wow. Great variety. That is really neat. Some places I have traveled to, a few I have not, or maybe I have I drove through in the past, but that's great. So I always like to start that off too because as a family therapist by training, we all have different family backgrounds and generational themes that create who we are as a professional and who we are as a person. So I think as we have the concept of aging and how we assess for older adult healthcare, we can't really fully separate that from what we've learned, growing up and how our parents and grandparents age, how caregiving comes into play, how we want to thrive, how we want later life decision making. It's tied in. So I always feel that there's a personal professional connection that's often a lot deeper with us than we think. And for those certainly that have grown up in more rural areas versus more city urban areas, the types of exposures you may have had to geriatric care growing up or a complete lack thereof. I think that also plays a part too. But it's great that you all are having an interest, or hopefully down the road will have an interest. This is a obviously growing population. It's one of the biggest populations we have in our healthcare system, and for the needs that all of you will have from medical, mental health, dental, PT, OT community. It really takes a village. So, as mentioned, it's really exciting to speak to all of you. A big thanks on the bottom to Dr. John Morley and Angela Sanford for their work and contributions, who have been the division directors of geriatrics here at SLU. Okay, so just a disclosure, this is obviously part of our 5-year HRSA Geriatric Workforce Enhancement Program grants. There's the QR code again for the demographic form, similar in the chat. So you have multiple ways. I'll make sure to only bug you a few more times on that, but great if you can fill that out for us. So, all right. Well, before we get into what is an age-friendly health system and some of the assessments that we have today, obviously we know that the aging population is growing, and you can see this rate of someone turning 70 every 7.7 seconds. That is a staggering rate, and we not only see this with the United States, we see this internationally. When we start to see trends of the aging population, what used to be a general pyramid, where you'd have the aging kind of at the higher tip of the pyramid, now it's inverted where it's almost a vertical column, where the 18 to 30, 30 to 44 are becoming similar age demographics and numbers as 65 to 80 and even 80 and up. So as we are growing, we're facing two huge conundrums in healthcare. One is a growing need of patients and how to fit them into appointments that we're having them address and how we treat those. And secondly, what's the workforce of specialists who can treat the older adult population? Some of you may have heard a physician called a geriatrician who takes care and specializes in health and medical needs for aging patients in primary care and in outpatient settings. That specialty within residency is declining. More primary care physicians are taking on the burden of older adult healthcare patients. We're starting to see that in our healthcare system. So there's going to be a crossroads here of how do we really develop more geriatrics informed professionals, not just those in primary care, but being able to do quality assessments and really detect prevention efforts to locate health conditions that are coming up more often. So I mentioned with the inverted pyramid that you see on the left, you can see that we don't even need 50 years from now, really in about 35 years, across genders, this is going to be more of, again, a vertical column, and it's going to actually invert as we continue to go along. With birth rates declining, with more mobilization, throughout different regions, those that are wanting to stay in place while aging, that's why those numbers are really ticking up. So again, having discrepancies in a growing older population and those just coming into the workforce, how are we going to be prepared to really address not only individual efforts, but take care of caregivers, really address community needs, try to fill in positions within the healthcare system that's already very overburdened with this area taking place. So, what are some of the comprehensive things we need then when we're looking at this growing population and looking at different healthcare perspectives? Well, the John A. Hartford Foundation and other organizations wanted to develop IHI, as you see on the slide, being another key one, developing comprehensive geriatric care and what is needed to assess older adults as they age, but also for healthcare providers to check in on what are some of the key metrics and categories that we can address here. So they really prioritized and came down with four main categories. The what matters category, aligning with specific health outcome goals and care preferences for older adults within the system. This is also not only for the patients, but for caregivers and family members. That's what really takes more of a family-centered approach. We want to give agency and communion to patient needs while knowing that we want to direct them in the best places possible and pass for their style of treatment. Second category is medication management. So obviously for an increase of co-occurring health conditions and syndromes in older adults, we want to see how can people get on safe and effective medications, but also where we can educate patients and caregivers in an effective way. When I've done several focus groups and even published an article over a decade ago, one of the top three themes that come up for dementia caregivers quite often with their healthcare providers is not being given a formal diagnosis for dementia or memory loss. That's consistently ranking in the top. So even the provider lacking a communication or explanation of the diagnosis, family members and even patients do not get. So how are you explaining the medication and that follows the diagnosis? What is this for? If you're not upfront with the family, it's going to cause a lot more confusion and frustration on their end. The third category being mentation. So how do we prevent, treat, manage, and identify diseases in other areas earlier? This is also for motivating older adults to stay active mentally. We have a really effective group here called cognitive stimulation therapy. Some of you may have heard it's an evidence-based intervention for people who are newly diagnosed with memory loss symptoms or even a formal diagnosis. But even those who are isolated and homebound, we're trying to find strategies in our healthcare system to really get people motivated to stay mentally sharper, to stay socialized. Many of you, I'm sure, that have worked with older adults, you may have had family members or close friends themselves who really struggled during and right after the pandemic. And I even think there's a big lull in older adults keeping sharp and keeping up with that mentation afterwards. So when you do screenings in healthcare, it's not only about a depression or anxiety diagnosis, it's how are people really motivated to keep their mind active and what outlets do they have? And then finally, of course, is mobility, staying safe physically as physical health and other stamina concerns may decline over time. How do we ensure that home safety or living situations are in a functional manner for older adults? We work a lot with our OT and PT groups for our geriatrics mobile van. Mobility testing is a really big part of that, and giving some education to caregivers when they go home that they can really meet those needs. So locking into the 4Ms, and you can use that across different settings, is going to be really key when all of you are going to be working with the older adult population. And you can see these are how many healthcare systems are considered age-friendly. There's over 8,000 different systems. Missouri, there's some overlap in the blue here of a fair number. Obviously, vast majority on the St. Louis, Columbia, KC side, but a lot more of these clinics are wanting to get to level 1 or level 2 age-friendly care. It doesn't take too much criteria to even get to a level 1. What it does is it prioritizes for patients. They can come in and work with those that are trained, or they implement 4Ms continually in their encounters and annual wellness visits. So there's benefit for the patient, the provider, but also the larger system in their PR for making it age-friendly and giving really comprehensive geriatric care. So really the goal when you're setting up the system, deliver the best care possible for older adults. I know that seems self-explanatory, but you have to make sure that you cater once we get to a certain point and lifespan, that there's a lot of adjustments that take place. And again, I'll always incorporate having a family-centered approach, a biopsychosocial approach in how you're managing the system of the patient just as much as how the patient's coping themselves, because that's going to be absolutely critical. Even if someone does not have a primary caregiver or someone they depend on, that should be a sign that you need to link them with a healthcare provider for them to stay connected. Also, that this recognizes the attempts to really reduce harm on patients, and not just through any of the 4Ms, but decision-making, quality of care, improving communication. Certainly older adults with increasing needs have to have a supportive staff and healthcare team that's by their side at all times. So, making sure that we emphasize a do no harm approach. Obviously, not just with older adults, but with family members, that they're getting quality of care and they're getting information they need. I always, in primary care, use what's called the 2-2-2 rule with caregivers. I want to allow 2 minutes to get in 2 questions and with 2 valuable tips that they can have. And if it's as simple as following a 2-2-2 or saving space, that can be the decision between someone trusting and coming back to you, or finding another provider, or not feeling their needs met. You're not going to fit in everything, certainly within a 20 to 30 minute appointment sometimes, but even a little bit of space makes a big difference. And then obviously improving the value of care, not just in the quality that people provide, but is it cost effective? Is it affordable for people that come in? And I know costs that accumulate for patients and financial burdens is a big topic that we're seeing in our healthcare system. So if there's any way that you can reduce that burden, that really is a big area. So now I'm going to talk about just the general term aging successfully. And I know everyone wants to have that goal, and it's in mind of how do we get from point A to point B. A lot of people want to thrive and also navigate what their latter part of their life is going to look like. But how the successful part's going to happen depends certainly on many things, and making sure that we give them the best care possible, but look into the prevention of this as well. So you can see when there's an arc that goes by age, our overall functionality and physical growth, our metabolism, and even motivations to do things, even timing, can peak. And usually when that gets into about the mid to late 30s, we start to see that not so much a decline, but how much time we have for functioning, for physical activity. That's usually on a slow decline until end of life. You can see here is where exercise really is key, but often can be a preventative measure. I often think if we bump this up earlier on the age spectrum, it can do wonders. So that's one of the biggest challenges, is how do we keep people physically active and still going while there may still be some co-occurring health issues that are coming into place. We also see with lifestyle behaviors, there's a lot of research. I'm sure all of you are starting to see there's big generational differences that are looking into health habits, even with drinking rates from the baby boomer and the older bracket of baby boomer generation compared to Gen Zs. Even their attitudes around drinking and food options and organic options are drastic. I think that's going to bode very well for all of you and younger generations as far as being more health conscious and preventative measures. And surely, not smoking, being physically active, moderate intake with alcohol or, refined sugar or foods, which obviously is strongly pushed against from healthcare providers, the ability to recover quickly from any physical illnesses or injuries, and identification or prevention mechanisms that people go into for visits. Oftentimes, though, for this last one, you do get people who not just resist coming in for an appointment or something specific, but even their annual Medicare wellness visit. We've seen a lot of no-shows and slight upticks in people over the years that want to attend those. People think if everything's good with my health or I can just manage it, why do it? So we're actually trying to find incentives here at SLU to having a pre-visit to the Medicare annual wellness visit. So it encourages people to attend the fuller assessment. But that's really important. But all these combinations can have significant increase in longevity for lifespan and age too. So I know the moderation in drinking has been controversial. They still show here the red wine benefits. So I know we can still be believers. Obviously, again, what impacts there's more macro level issues and specific in genetics. Environment, certainly socialization, people that have access to walking or biking paths. I know there's a lot of geographical data out there that correlates with health and early morbidity, mortality risks. Obviously, genetics plays a huge impact in that. If you're a provider, getting family history is not about getting data on a sheet. It's about linking information and giving you a sense of how people want to prioritize their health and what they've seen in past generations, and do they want to do similar or different patterns from that. I always say use quantitative data from family into qualitative solutions. That's a big thing that you want to take from family history. We emphasize a lot of our mental health professionals to also look into that as well too. Lifestyle factors. I'll do kind of a quick chat answer or break in here. I will give you 5 different factors of health, and you tell me what would be the biggest risk factor for a early onset in dementia. Number 1 would be poor diet. Number 2 would be lack or very minimal exercise. Number 3 would be poor sleep or long-term sleep deprivation. Number 4 would be chronic stress. Number 5 would be very minimal socialization. Put in the chat what you think would be right now what we're seeing trend-wise as the biggest risk factor for dementia. Poor, bad diet, lack of exercise, chronic sleep problems, chronic stress, um, lack or minimal socialization. All right. Let me see here. Oh, we got stuff. All right. Sleep, socialization, 5. All right, that sounds good. Anyone else? I need a few more to kind of round this out here. Diet, exercise, sleep, chronic stress, or socialization. Here we go. You're trickling through 5, 4, 3, 2, 1. All right. Well, a few of you got it. It is actually chronic sleep deprivation. So, um, which obviously the other ones are super important, but we've also seen a association in our memory clinic that for those have had, and not just months, I mean, but years and years of underperformed sleep. And again, where people may be, having sleep apnea or, narcolepsy, sleep disorder issues as a result, that is a big, big risk factor that comes about. So wherever you practice, whatever rotations, make sure that if it's memory loss related, always assess for sleep. I can't tell you how much that's glanced over, not just for older adult memory loss issues, but just for older adults in general. Not all older adults get good sleep, not have had a good track record as well too. And then obviously with social events, for displacement from natural disasters, obviously, through the pandemic, we've seen there's, a lot of other barriers and challenges that certainly get in the way. So early assessment and recognition, why is this important? Obviously, we want to identify things, some that may not be reversible, but where we can catch early enough that can be monitored, and also where people can continue their functional status and physically, they're not at risk for more hospitalizations or, like you said earlier, nursing home admissions, and improving again their mentation as part of the 4Ms and social functioning. They can still get out and do these things as well too. When we've been catching something early in geriatrics or family medicine, we always want to try to integrate another professional or give a referral option. So, people are still keeping active in what's working well. And for us, being more strength-based instead of the patient saying, I have a new diagnosis or I have a blood test result or a complication. I'm going to obsess or worry about that and put everything on the back burner. That's where days lead to weeks, lead to months, when they get away from keeping up with what's working well. So age-friendly begins with assessment. I'm going to go through at SLU, we use quite a bit called the Rapid Geriatric Assessment. Some of you may have heard of the assessment. We'll go through it in depth, so you will be plenty aware of it at the end of the talk. It's a brief screening tool, can take about 4 to 5 minutes. And within each quadrant, it can really, take even a couple minutes. It's validated in various settings. We've used this in primary care, across family medicine and geriatrics. We use this in community screenings. We use this in our community mobile van, as I mentioned. It identifies really 4 common, more underdiagnosed geriatric symptoms: frailty, sarcopenia, nutrition or malnutrition, and cognitive assessment and cognitive decline. This can be administered not only by a medical professional, but other professionals who are skilled in this area. So this is the general 4 quadrants of what it looks like. Again, some are a little bit smaller than others. If you do a rapid cog screen, and we'll show a video example of both of these, make sure that you give enough time. With the rapid cog screen, this is also a precursor that if someone scores low or is at risk, we normally then want to expand a larger SLUMS, St. Louis University Mental Status Exam, sometimes MMSE, to really get a more comprehensive picture of what's going on. Sarcopenia for muscle strength is really important too. A lot of these also overlap where, frailty scores that are in a greater risk aligned with sarcopenia, where someone may be more fragile in their physical makeup. And then nutrition obviously is really, really important. Can often overlap with some of those other areas too. So we've seen in about a decade of longitudinal research and data collection, both at SLU and some of our community partners and places that we've collected. This is a sample of over 16,000 older adults. So, we've used the RGA quite a bit in different areas. You can see the breakdown just by age and how this really looks here. And, if you look at rapid cog screen for 85 plus, in that category, and those who may have a percentage who qualify or meet for dementia, you can see that that goes up quite a bit. Normal cognition, again, in a lower older adult range, you'll see that a lot more. So the decline will be pretty noticeable for that. Same thing with frailty. You see in the gray boxes here. So frailty for a 10-year span across each category, that starts to go up. So you see a lot of trends that happen across the different quadrants. That's why it's important to not only get a sense and follow up by age, but also know that it's age specific. What can the patient really do to address these? Because there's a lot more limitations if a 87-year-old has really poor muscle strength and is starting to have cognitive decline. That's where they're going to need family, other support systems involved. Someone at 66, again, may physically have a little bit more stamina to address these or get to more appointments. So when you crosswalk over the age and types of physical syndromes, that makes a big difference. You should also notice too with advanced directives. I don't know how many of you have worked in a hospital setting or have done a rotation on inpatient yet, or will. I know you'll all get that exposure at some point. We go through a lot of challenges, and I was just at our hospital, our residency hospital this morning, and we had a lot of older adult patients on the list. So I prepped our student by saying, you're going to see a lot of issues, including, do they have an advanced directive? Do they have people that are involved in their care? So this is really staggering. The amount that have an advanced directive, a person who makes healthcare decisions and a power to, goes from 54 to 74 to 83, just within about a 20-year age span. So, again, we're almost at 50% not having one in 65 to 74. That's a huge number. So, no matter what you're working with across these levels of ages, making sure that you ask them questions, putting the priority and the necessity for making sure that they have someone aligned. It doesn't take too long. There is some paperwork. You also, people work with wills and trusts. That can be one of the documents that can be packaged in when they work on that for financial or estate planning as well too. So that does not take too long at all for that. And you can see we've had some publications on RGA and how to create an age-friendly health system. You can certainly check that out. We just put out an article within this past year, different morbidity risks for older adults using the RGA data, so looking at different associations that take place, and just in general how to create an age-friendly health system is out there. So when you're focusing on frailty, and I'll see if I can break up a few small videos for this to give you an example, really the diminished capacity to carry out activities when under some undue stress. So this is different than a disability in that if there are organic degenerative issues happening within the body versus a long-term physical disability, it's really going to prevent people, walking a full block without being out of breath, going up a flight of stairs, being able to grip or hold things. So as coordination problems are happening, how transparent are the patients with their healthcare team around this? So the goal is really to identify this before someone maybe becomes at a disabled state and can't really function or use their right leg as much, or their grip strength is so weak they need others to carry things, or they can't go to places because they can't carry things. So we do a simple frailty screening tool. It's in the acronym of FRAIL. Are you fatigued walking a flight of stairs, walking a block, the comorbidity of 5 or more illnesses, and 5% of weight loss over the last 6 months. So we can see this cascade from a biopsychosocial perspective kind of funnel in that if you have multiple risk factors from a mental standpoint, social community, or a genetic standpoint, this is going to really impact your activities of daily living, which will lead to increases of hospitalization and long-term care options. So once you get to these steps of frailty, this can cascade very, very quickly. So our goal is the more that we can even assess for people frailty-wise in earlier stages, that makes for a huge difference in their care.
About your
I'm going to show a brief video. This jumped right into it. Can all of you hear the audio? If I played that, someone can unmute with a yes if you can hear it.
Answer them by how you usually feel most of the time,
You can hear
not
it. Okay.
just today. Are you fatigued or tired?
Yeah, I'm kind of tired all the time.
By yourself and not using aids, are you able to walk up one flight of stairs without resting?
That would be kind of hard for me to do that.
Are you able to make it up and down the stairs?
It's kind of hard. I have my laundry is downstairs, and I haven't gone down there to do laundry in quite a long time.
Okay. So not able to climb a flight of stairs.
Yeah, those steps are really hard, and then when you have laundry in your arms, it's hard to do safely.
By yourself and not using aids, are you able to walk one block or several hundred yards?
Yeah, I can walk a block.
What illnesses or conditions do you have?
Oh, goodness. I have high blood pressure, and my cholesterol is too high, and I have atrial fibrillation, my heart's not regular, and some diabetes, and asthma, and a little heartburn. My doctor told me my bones are kind of thin, and I'm getting arthritis in my knees.
Okay. And have you lost weight in the last 6 months?
Yes, I have.
How much weight have you lost?
Well, based on my checkup 6 months ago, it would be about 25 pounds.
Okay. Okay. A score of 0 on the Frail questionnaire indicates a healthy older adult. A score of 1 to 2 indicates pre-frail or early decline, and a score of 3 or more indicates decline and frailty. Rose scored 4 out of 5. She got 1 point for fatigue, cannot walk up one flight of stairs, has more than 5 illnesses, and has lost more than 5% of her body weight in the last 6 months.
Okay. All right. So back to the chat. After hearing Lois and some of the issues that she's going through, what would be some concerns that you have? Lois also, I believe she was in her late 70s for this video. So someone late 70s, high frailty scores. What would be some red flags that you would have if you rated this in an outpatient session? I will, as I move on to sarcopenia, you can put in the chat. It can be just some general concerns or statements based on what you heard there. We'll move on. Sarcopenia, muscle structure and functioning. So again, this has a little bit of overlap with frailty, but now we're starting to lose on. We're starting to focus on the loss of muscle strength, even if active and even if socializing or being physically mobile. So really, it accelerates around 65. So around when we get to a older adult, at the threshold for age. People that are physically inactive, this is staggering, lose 3 to 5% of muscle mass per decade. So, those that are homebound or not doing much physical activity, even in their 40s or 50s, you can see where that really starts to snowball quite a bit. At our summer conference, I'll put in a plug for that at the end. We're having a few talks on how to create a home safety and aging in place spaces where people can thrive and still be physically active and socialize, because the importance of someone still wanting to remain in their home, but restructuring how their home environment looks, or if they go into a long-term care facility, how it's not just the physical structure of the home, but also healthcare wise and mobility that they can get around in the best way possible. So we've been highlighting and trying to target that quite a bit here. So okay, so for the SARC-F, again, strength, assistance in walking, rising, getting up from a chair, climbing a flight of stairs, and how many fall risks that they've had within the past year. So again, if there's a higher score on this, this is a real risk factor for overall muscle strength and muscle mass, or percentage that they have to really utilize for themselves there. So
Yeah.
I'll skip that video. We'll get to the cognitive one. The weight loss in older adults, again, this overlaps a lot with nutrition, but also with muscle strength. This is also a big thing to keep on your radar when you're assessing for certain areas and syndromes. It may not only be the weight itself, but part of an underlying medical disorder. So you really want to do a thorough assessment of what's happening. Also, if you can get a caregiver or family member to give you additional data, if they may give you information about an event or a significant situation or something negative outside of anything physical, that can certainly do a lot to that. Loss in the family, financial issue, displacement, a separation, whatever it may be. So, and dieting after 65, countering too many of the trends that we have in society can pose increased health risks. So, as many of you have probably heard, having or carrying a little bit of weight into older adult years can be seen as a protective factor. Certainly, you want to be able to eat and have a balanced diet, but when muscle mass decreases in addition to a lower weight level that older adults have, that can mix for a really, really bad situation, and contributes long-term to memory loss and other immune disorder syndromes that come up. So this is called the SNAC, just abbreviation different. Around appetite, how much people eat, how many meals a day, and when feeling full, and how good or bad food tastes overall, which that's really important, because that is not even indicating what types of meals they're bringing in. But again, if there's any sensory problems or challenges, that's just a barrier for people motivated to want to eat and to take place. So then I'll get into mild cognitive impairment versus dementia, and this I'll show the brief clip because this will be important when you're doing some screenings with patients. So MCI, as all of you know, that's early signs and some symptoms and warning areas for potential long-term memory loss. It interferes, in some areas, but not with daily living activities that take place. It has been increasing in adults over 65. I think there's been some debate as far as how long can people stay in an MCI versus if that gets into some form of dementia. So again, some of the literature is still unknown at that point. So the goal is to at least prevent permanent damage or memory loss from taking place. So this is why early screening and prevention and getting people into their annual wellness visits or their general checkups with their primaries is really, really important. So unlike dementia, where there's a decline in one to multiple domains, again, executive functioning, being able to order and prioritize daily life activities and skills, spatial recognition can get lost, language, being able to bring up appropriate words, attention to detail, learning new information is challenged. If we see that in multiple areas, that's a pretty clear sign, and that there's significant decline taking place. So if people go to MCI to a early stage of Alzheimer's disease that has been diagnosed in their chart, this is really the major jump and where it is more progressive and it's debilitating and disabling the patient from doing things in multiple areas of their life. This could be having organic mechanisms as well. If there was a delirium episode that was acute that may cause maybe then acute memory loss, that's different than obviously long-term degeneration. If there's long-term alcohol or drug use, if there's other medical conditions that may prompt risk factors to consider that. So, but about 5 to 8% of those over 65 and 40% of those over 90. So, this is not just an end of life disease. We want to make sure that we have even people we've heard in their late 50s getting early onset Alzheimer's has not been uncommon coming into our clinic, getting into groups. Unfortunately, that is a very troubling trend that we're seeing much earlier stages for this. So the dementia's acronym, drugs, emotional capacity, metabolic syndromes, eyes, ears, normal pressure, tumors, infections, anemia, and sleep apnea. You want to see, in addition to memory loss, what other co-occurring things are taking place. Again, I mentioned our mobile van. Well, we had a standing geriatric assessment clinic, which is now our community van service. We try to cover as many of these as we can. And when we coordinate as a team, we see, what is overlapping. Even people with initial hearing loss or impairment, socially isolated, may talk about more sleep problems. All those factors are going to contribute to potential long-term memory problems. So we want to give a good plan of care and really be proactive in catching these. So this is the rapid COG screen. This is the final one within the RGA. You probably know the question, the repeat and retention, the 5 items: apple, pen, tie, house, and car. I can say that quickly because I've seen the RGA 1,000 times. And then on section 2, you want to do the clock drawing. So giving the hours of 10 minutes to 11, that they have the numbers correctly in order. They have the short and long hand in the right positions. And then what were the 5 objects? You do a recall of that and you score that. Really, if I see someone at about a 6 or lower, I usually encourage that we do a longer slums or MMSE so that we get really a comprehensive view. It's not a one-time isolated incident. People may have been anxious. They may have been distracted. You have a little bit more reliability doing it that way. So,
Lastly, I'm going to ask you some questions about your memory. Some are easy, some are hard. Do your best. Please remember these 5 objects. I will ask you what they are later. I will read them to you and you repeat them back to me. Apple, pen, tie, house, car.
Apple, pen, tie, I'm sorry, I can't remember the other 2.
I'll repeat them again. Apple, pen, tie, house, car.
Apple, pen, tie, house, car.
This is a clock. Put in the hour markers and the time at 10 minutes to 11 o'clock.
You want just markers?
I'll skip this a little bit for timing.
Apple, pen, tie, I don't think I can remember the other two.
Okay. I'm going to tell you a story. Please listen carefully because afterwards I'm going to ask you about it. Jill was a very successful stockbroker. She made a lot of money on the stock market. She then met Jack, a devastatingly handsome man. She married him and had 3 children. They lived in Chicago. She then stopped work and stayed home to bring up her children. When they were teenagers, she went back to work. She and Jack lived happily ever after. What state did she live in?
Well, they lived in Chicago, so that means they would live in the state of Illinois.
Rose scored 6 out of 10 on the rapid cognitive screen. The higher the score, the better the cognitive function. 8 to 10 is normal, 6 to 7 indicates mild cognitive impairment, and 0 to 5 indicates major neurocognitive disorder or dementia.
So you can see with Rose, I called her Lois on the last slide. I must have a new name pops up. But 6 out of 10, I would have a little bit of concern even with that brief assessment and may look to expand what's happening or what's going on there. If anyone wants to put in the chat, if you've had experience doing assessments with older adults or even patients, having a brief one time, what might be some downsides to doing that or why a score may not be valid, feel free to put that in the chat because there's a lot of reasons. Rose may have scored low, but if you have any ideas or any experience of why people may struggle one time, you can put that in there. So management of cognitive dysfunction. So, we mentioned some of the prevention mechanisms and some of the risk factors. When we talk about treatment planning, minimal educational background, very good. I agree. So, timing, anxiety, health literacy, that's a great point you put in the chat. Thank you. Excluding some of the treatable causes, I think are important. Lifestyle, when you do planning, especially if there is some cognitive challenges, nutritionally looking at a Mediterranean diet, they mention olive oil. John Morley, who was our previous director of GWEP and the geriatrics division, said he always encouraged people with early signs of memory loss should have a liter of olive oil a week. So that's quite bold. I think I use it quite a bit on pan and dressings and all that, but if it really makes a big impact, start looking at the grocery store for that. Exercise, even socialization or interactions on the computer or ways to challenge the brain can be impactful. I mentioned cognitive stimulation therapy. That's a group for those with mild to moderate dementia, psychosocial group intervention and series of themed activities. The Alzheimer's Association has some really good network within Missouri across different states. The safe return bracelets for safety reasons, if someone wanders and gets lost, they have really good technology now for tracking and I know Apple has a lot of new devices now that we can kind of monitor where older adults are at. Always have the discussion around driving and around gun storage. Safety issues are not just fall risk. Those who want to push back and want to drive may go against the doctor's demands. Doctors can strip the license or take that away if they deem that a patient is unfit or unsafe to drive. But the family member really has to be involved in that and on board. And then gun safety at home, we hear not too often, but really unfortunate situations of fatalities or even injuries due to guns not being locked up, stored properly, people being disoriented on knowing around that, even locking up in the first place. So make sure you take care of that. We went through the scores and all that pretty well too. And then we'll just say, don't forget about caregivers. We have a rapid caregiver well-being scale, a 6 item that's a reduction from a longer version of this that my colleague Marla Bergweger and others had developed. We use this in our clinic a lot. It's 3 questions on activities of caregivers, daily activities, family and friends socialization, rewarding yourself, and then 3 self-rated questions on healthcare, feeling good about yourself, financial security. Usually, if there's some risk issues or some lower numbers, we try to get caregivers involved in that plan of care as well too. So, again, to wrap up, make sure that you really incorporate your 4Ms when you're working with the older adult population. Make sure you memorize this, get to know the specifics of what assessment areas align with any of these 4 categories becomes really important. These are some of the areas that we're working on at RGWEP. In behavioral health, we have a lot of group interventions. Interprofessional practice, I mentioned the mobile van. We have a collaborative team of 5 different disciplines that go out to partner sites. We also have a lot of student-focused trainings and initiatives. Alzheimer's related with CST, we're piloting a Dementia 360 that helps providers know at what stage of dementia, what referral and resource mechanism is needed. And then even in the long-term care setting, Susan Elliott and Christina Traber are developing several different innovations, including an Act-On tool that really monitors risks that maybe an older adult patient monitors or their loved one based on settings. So some really neat stuff that we're doing as well too. And then building on the RGA, we're also piloting what's called a 4Ms clinic in our primary care system so that a behavioral health provider works with a geriatrician or a nurse practitioner to develop what's called a pre-visit from the Medicare Annual Wellness, so you can screen 4Ms, give it to the provider, and when the patient goes back to their annual wellness visit, it can go quicker, and they already have a sense of what referrals or resources can be met. So we should have some data as we go along this year, but I think patients have found it very valuable when they've been coming into it. We also have a lot of videos in our library. This is the QR code. If you choose, you can pull out your phone and look at it. We have a link. Family Center for Healthy Aging is on our YouTube channel. We have a lot of brief clips, a big library. So if you need guides and tips and language, it's a one-stop shop, and it's really, really good. Would strongly encourage you to check it out. They have a lot of other tips as well too on it. Then cognitive stimulation therapy, we developed as a group intervention, as I mentioned, for memory loss that really hits on more mentation, developed out of the UK, and we've adapted it. We're the largest North American institute that does training here as well. And then caregiver process groups and loved ones. We have a speaker series. We partner with Louisville. So if any of you or patients or caregivers want to attend, it's the second Monday of the month, 12 to 1. We can certainly put you on the listserv for that. And then we have events coming up. So I will jump right to this. So this is our Healthy Aging Conference in the last minute or so here, June 5th and 6th. It is for any students free of charge. So that's really nice. You don't have to spend a mortgage payment to go to a medical conference. You get that covered. Some great stuff on June 5th. It has a list of topics on medication, health disparities, AI, home health, behavioral health. Some really neat stuff. If you want to submit a poster, there's a call for abstracts. That QR code is here. That's going to be closing down in about a week or so. So if you do want to get a poster, or you have an initiative or a capstone project for a course, feel free to do that there as well. Again, the link, thanks, is also in the chat. And then here's just a little description on the left about the conference itself, and then the poster session, again, is on the right. So feel free to reach out to us. You have about a week or so, again, if you want to submit something. The posters are really general as far as topics and themes are concerned. So Our main thing is we want to encourage people to be able to present on different topics. If you want to incorporate any of this information, if you have something specific, dementia-related different syndromes, people done stuff on diabetes, chronic pain, behavioral health, whatever it may be. If there's dental and oral health concerns, if there's physical challenges, if there's other screenings or case studies, you can do that. So again, for the fourth time, here's the demo form with the QR code. Please make sure to fill that out. And if nothing else, I will stop share. And I'm over time. I don't know if anyone has any quick questions in the chat or choose to unmute. All right. I don't see any coming up. Hopefully all of you have an interest in working with older adults. Final chat thing, if anyone puts their hand up or a thumbs up or a yes in the chat, hopefully we get at least one person out there that has an interest in older adults. But absolutely, you can reach out to us with any questions, but again, these are going to be really mainstays when you're working with that population, and hopefully you can come to our conference, swing down here and attend. So wonderful. Just completed the rotation. Great job, Jenna. That's awesome. So, all right. Well, I think that's it from my end. Otherwise, I really appreciate taking time out today.